Hello, I'm Dr. Doug Drevets. I'm the Chief of Infectious Diseases at OUHSC, and it's my pleasure to be here today with Dr. Dale Bratzler, the Chief COVID Officer for OU.
So, good morning. Dale Bratzler, University Chief COVID Officer. I'm going to give a brief update on where we're at in Oklahoma with respect to COVID-19 and then highlight a few recent studies that have come out that we thought were interesting to talk about. So just earlier this morning, the State Health Department updated our numbers for today. We're at 208,875 confirmed cases in Oklahoma. 24 more deaths were reported today, so we're at 1,860 deaths in the state. I think that's remarkable. When you look at the past 7 days in Oklahoma, we've had 21,308 new cases confirmed in the state and 156 deaths, which is the highest number of deaths in 1 week that have been recorded, recognizing that not all of them were actually occurred this past week. I think the other thing that I was struck by this morning was the number of cases in the United States now. More than 200,000 cases a day are being confirmed in the United States, and an American dies every 2 minutes. 2 Americans die every minute from COVID-19 right now. So the number of deaths and the number of new cases in the United States has just gone up dramatically. In Oklahoma, we've looked at maybe some encouraging news as the number of new cases reported for the past several days had dropped a bit. The health department did report that there was a delay issue in their reporting system and reported 4,800 new cases today. But the 7-day rolling average as of this morning now is 2,558 new cases on average daily. In the handout that will be distributed, I highlight the population incidence of COVID-19 new cases in Oklahoma. And again, very much a rural disease right now in Oklahoma with rapid spread of the virus and a number of new cases in many rural counties in our state. Ellis County, as an example, had the highest population incidence of COVID-19 in Oklahoma right now. So far this week, the State Health Department has reported the results of 127,845 COVID-19 tests, which is a large number that included the extended weekend. Of those, just under 15% remain positive, and that number simply is not going down, which gives me great concern about the ongoing new cases that we're going to see in Oklahoma. And then finally, hospitalizations have been the big news, obviously. As of yesterday, there were 1,687 hospitalized patients in Oklahoma, with 482 patients in the intensive care unit, just under a third of the patients. 482 ICU patients with COVID-19 is the highest number we've had since the start of the pandemic. So sadly, as I've mentioned before, we're going to continue to see deaths from this disease with people that sick that require ICU level of care. I put out a couple of other statistics in the handout that will be distributed. I just wanted to highlight what happened in Oklahoma in November. In November, we had almost 75,000 new cases confirmed, which was 37% of all of the cases that we've had since the start of the pandemic. So we saw, very rapid community spread of the virus during the month of November. There were 406 deaths that were reported during the month of November, which is 22% of all of the deaths that we've had. And if you look at the number of cases per 100,000 population per day, we were at 27.6 cases per 100,000 population per day on October 31st. At the end of November, we were at 76.6 new cases per day per 100,000 population. So you can see that the transmission of the virus has gone up very dramatically in the state. I also highlighted in the handout this week a study that came out of children, because one of the questions that's come up a lot is, do children get infected in the home? Do they infect their parents or vice versa? And this particular study, relatively small, but out of 2 states, Utah and Wisconsin, showed that the rates of infection between both adults and kids in the household was almost identical. Right around 30% of the people living in a household with an infected patient became infected. But the one thing they did note is the kids often don't have symptoms. And if they have symptoms, they're different than adults. So a lot of the cases simply get missed in the home. So household transmission with kids in the home is probably more common than we've thought at some point, but it's very, very important to recognize that it can occur and may occur just as often with kids as it does with adults. One of the interesting discussions that Dr. Drevets and I and many others on this campus have been talking about is how many people in Oklahoma have had this infection. So we know from numerous infectious diseases that the number of people who get a test done and test positive is often much lower than the number of people in the community who've had the infection, but they either had no symptoms, didn't get very sick, so they never sought medical care and never got a test done. And the estimates are all over the map on how many people that might be. So the Oklahoma State Health Department reports in their weekly epidemiologic report that about 20% of the specimens that are tested for antibodies in Oklahoma are positive right now. So that might suggest that somewhere around 20%, yet we know most Oklahomans don't get antibody tests. The CDC published a study that went through the end of September looking at, again, positive antibody rates, and we know that antibodies don't last forever. And they suggested that less than 10% of the US population had circulating antibodies to this particular virus. But the one that caught my attention was a study that was a bit more recent, a modeling study that came out from the CDC that's in press right now, and they suggested that for every one infected person, there may be between 7 and 8 people in the community that were infected, didn't have symptoms, didn't get a test done, didn't seek medical care. And so again, the estimates vary widely, but it has real significance when you start thinking about how rapidly the disease spreads if you have a substantial proportion of your population that's already had the infection. And then the last study I'm going to highlight is actually a guideline. It comes out from the National Institutes of Health. It was updated. It's the treatment guidelines for COVID-19. I'm just going to highlight one important point. When a person gets infected with COVID-19, there appear to be 2 phases of the disease, particularly for the people who are symptomatic who get really sick. The first phase is when the virus is growing. It's spreading through the body. It's replicating. And for that particular phase of the disease, we use drugs like the monoclonal antibodies to try to slow the spread and growth of the virus. We do not use steroids and should not use steroids in patients who aren't sick enough to be in the hospital because they can actually make it worse, because they can allow the virus to grow unchecked and spread in the body. Then the later phase, particularly for those people who get sick enough to be in the hospital, the focus of the disease shifts, and it's an exaggerated immune or inflammatory response. So the body's own immune system starts attacking the body and causing the tissue damage that results in the trouble breathing and shortness of breath. And that's where we use drugs like dexamethasone or the steroid drugs, which try to blunt the immune response to the disease. So it's very important to understand that there are different phases of the disease, and what treatment a person gets depends on where they're at in the spectrum of the disease. I know Dr. Drevets and I were notified by one of our intensivists that they've seen a few patients who have inappropriately received steroid medications who were not hospitalized, and that should not happen because that could potentially make the disease worse during that early phase.
So that makes me ask, if someone is receiving steroids for something else and yet they were asymptomatic for COVID, but they had it and didn't know, I mean, what are the ramifications of that?
Well, so we know that anybody who's immunosuppressed, whether from medications like steroids or cancer chemotherapy, they're at greater risk both of the infection and of the complications of the disease. We've known that for quite some time. So again, I'm principally focused on those people who aren't routinely taking these drugs. And if you're an outpatient, please don't be asked to be put on steroid medications in the outpatient setting, because that blunts the immune system, which is what you want in the second phase of the disease. But in the first phase of the disease, it could allow the virus to grow more rampantly, and that's what we don't want.
And going back to another thing that you said about in November, the positives that we had were 37% of all, since the beginning, since our first case in Oklahoma?
That's correct. During the month of November, we confirmed 37% of all of the newly confirmed cases that we've had since the start of the pandemic in Oklahoma. So there was just very rapid community spread of the virus during the month of November.
And really looking at December, similar to holidays and get-togethers, and it's cold, and
Yeah, so I think for the month of December, of course, we're still waiting to see, is there a bump in the number of cases from Thanksgiving? And we actually don't expect to see that show up in the data until perhaps next week. So we cannot let our guard down right now. There's still community spread of the virus. We expect that there's a good chance that the numbers will bump up next week from the Thanksgiving holiday, and then we have Christmas looming in the very near future, and again, a time when people typically congregate, go to religious services, come together as multi-generational families, which all have great risk of spread of the virus right now.
Before we move on to ask some questions about the vaccine, I wanted to, you had talked about plasma, and we had a reporter asking about, she interviewed a couple that, or he interviewed a couple of, at the Blood Institute that were donating plasma. They had COVID in March. This was their 4th donation, and the OBI said there was still plenty of antibodies in their plasma. Is it normal for there to be a significant amount of antibodies in someone's system that long? If not, how long is the average of the antibodies? And then should they feel confident that they still are immune because they still have the antibodies?
Well, so that's a complex question about how long do antibodies persist, and are you still immune if you have antibodies in your blood? So the first thing is every person is different. Some people who get COVID-19 have limited antibody responses and don't have much in their blood. Doesn't necessarily mean they're not immune, because remember, there's a separate immune system called the T cell system that doesn't have antibodies in the blood but may protect you from the disease. So we honestly right now do not know how long immunity to COVID-19 might last if you've recovered from the infection. Second, some people do generate lots of antibodies, and those are the people that people hope are donating plasma that might be used to treat patients, particularly in that early phase of COVID-19 when you're trying to blunt the spread of the virus through the person's body. So it's variable by person. Some people have lots of antibodies when you test them. Some people have very minimal.
Okay, I am getting a couple of questions about vaccines, so let's move on to Dr. Drevets for a few minutes, and it might help if you answer, if you'll repeat the question, because they can't always hear me. So, if you've had COVID, well, first of all, can you just give us a little bit of an overview about the vaccine, the first vaccine that we're going to see in Oklahoma, and just kind of let people understand that it's not just because it shows up in Oklahoma that the average person on the street is going to be able to run to CVS and get it right away, right?
So the first vaccine that we will receive in Oklahoma is the one produced by Pfizer in collaboration with a German firm called BioNTech. Interestingly, so this is the vaccine that was approved in the United Kingdom just earlier this week. So it has gone through significant vetting, both for safety and for efficacy. We will be receiving a limited supply of this vaccine because it's being distributed all across the United States, and then of course also in the UK. The other thing that's really interesting about this vaccine is it requires ultra cold temperatures for stability. And by ultra cold, it's -70 to -80 degrees centigrade. So this is not your average freezer. This has to be in a special freezer. And so it's being distributed to centers across Oklahoma by the State Department of Health, who have the capability to store and then administer this vaccine.
I've had several people asking about side effects. That's the big question. They want to know when people start getting it, what can they expect when they get the
So with all vaccines, you get a jab in the arm. This vaccine is administered intramuscularly, just like many other vaccines, like the flu vaccine. The details will be released when the FDA approves it for emergency use, which we hope will be next week. What I've been reading from other publications is that the most common side effect is pain at the injection site, fatigue, and headache. And those happen in anywhere from 30 to 60% of people, but are generally mild or moderate. There are very few severe reactions with this vaccine, and by severe, they mean something that's bad enough so that somebody can't do their normal acts of daily living. So a low-grade temperature would be considered a mild reaction. A high fever of, say, 102 or 103 would be considered a severe reaction. So by and large, people can get this vaccine and carry on. At least in the literature for the UK, these types of side effects are commonly treated with antipyretics, such as acetaminophen or ibuprofen, and really can be well tolerated.
When the vaccine shows up, I'm gonna ask both of you doctors, would you, and they say, Dr. Drevets, get in line, it's time to get your shot. You up for that?
I am absolutely up for that, and I'm looking forward to it.
And tell me why.
Well, you know, I see patients with COVID as part of my job. And although I have not had COVID yet this year, which is great, you know, there's always a risk. So I want to protect myself in part. It will also help me protect others because the presumption is if I don't get sick, then I can do my job more effectively, and I'm less likely to harbor COVID and then spread it to somebody else. You have to remember that natural immunity is a great thing. It's how we live. But remember that there are diseases such as smallpox and polio and many others which really caused devastating infections before we had vaccinations. So although natural immunity helps us survive, it does not eradicate these infections by any stretch of the imagination. And so we really need both, and we really need the vaccine to get back to something like what we think is of normal life.
Dr. Bratzler, first of all, you're up for getting the shot when the vaccine when it
Yeah,
comes out?
absolutely. I'll be in line to get the vaccine when it's offered to me. I actually see patients in an ambulatory clinic for the uninsured, and as I've told all of our clinic staff, you know, you just have to assume that anybody you see in any setting could be infected. So I wear full personal protective equipment and we have our patients in masks, but I have to assume that some of the people I'm directly interacting with in clinic could be infected. So second, I just hit age 65, so therefore I am in one of the high-risk categories now for phase 2 of the vaccine distribution plan. But the third reason I will is because, you know, I had questions about particularly these two vaccines from Pfizer and Moderna where they inject a small amount of genetic material that rapidly gets destroyed. But I have a very close friend who is a lead vaccine researcher at the National Institutes of Health who went through some of the history, the development of these vaccines. They've actually been in development for many years, and she made me feel very comfortable that these vaccines would be safe and effective, and she would line her family up, so I will certainly be in line to get the vaccine also.
All right. And Dr. Drevets, get back to a couple more questions for you. And if someone has had COVID, should they get the vaccine?
You know, the question is, if somebody has had COVID, should they go ahead and get the vaccine? And the answer is in general, yes. Particularly if you're in one of the high-risk age groups, high-risk groups because of age or because of underlying health conditions. And there are a couple of reasons for that. For example, as Dr. Bratzler said earlier, we just don't know how long immunity to COVID lasts. Is it short time? Is it long time? We do not know that answer yet. Secondly, for most infectious diseases, if you get vaccinated after you've had the infection, you don't have necessarily a worse reaction. But yet it can boost your subsequent immunity. The third reason is many people who have had COVID, particularly in Oklahoma, have had mild symptoms. It's very clear already that people who have very mild symptoms have much lower antibody responses than people who have severe symptoms. So if you had a mild case of disease back in the summer, there is a good chance that your antibody levels have already started to decline. And so you would in fact be helped by having the vaccine.
So that kind of goes into the question about how important is it for the general public to get the vaccine? And I think you both might want to comment, because that's really the question of the herd immunity versus from natural immunity versus vaccinated immunity. Is that right?
Right. So I guess I would turn the question around: is how much, how badly do you want to get back to what you think of as a normal life? That's how important this is. We will not eradicate this infection just by herd immunity alone. It will continue to percolate, just like polio continued to percolate in the United States until vaccination started. For those of us old enough to remember polio, or seeing patients with polio, it's not a pretty picture. And you can choose other types of vaccine preventable diseases. For example, measles. We have a wonderful vaccine against measles that induces very good immunity, yet some people refuse to get it because of particular beliefs. If you get enough people like that in a certain area and you get a case of measles, which are often imported from other countries, then you have a small epidemic and an outbreak there. Measles has not been eradicated by natural immunity. So I'm a big believer in natural immunity, and this is how we live and survive. It's the way we're designed. But we need something else, in a sense, to eradicate a disease. The reason we don't have smallpox anymore is simply because of vaccinations.
Well, no, I agree. I mean, so as I've told the students on the Norman campus, if we want to get back to what the students would see as kind of a normal university experience next fall, then we need to see a substantial proportion of the population vaccinated, so we can get back to what many of us consider the old normal, which is to dramatically reduce the number of cases that are spreading, so we're not overloading our hospitals so people aren't getting infected. Again, I'm going to highlight again, 2 Americans die every minute from this disease, despite the level of infection we've already seen. So, for me, the vaccine is a glimmer of light at the end of a tunnel that's been pretty long. And I think if we really buckle down for the next couple of months, do all those public health measures as the vaccine is rolled out to first the high-risk populations and then eventually moves to the general public, we can actually get back to some sense of normal, completely reopen the economy, get our schools open for our kids. That's the only way we're going to get there, is if we reduce the number of cases that are occurring.
Dr. Drevets, that kind of leads into this next question about what are your thoughts on the phased process of who gets the vaccine first? This specific question is, well, let's just leave it at that.
So the question has to do with, why is the vaccine being rolled out in phases as opposed to having just having everybody have access to it immediately? And it has to do with the fact that the initial supply of the vaccine is going to be actually quite low. When you think there are 4 million people in the state, and we may have an allocation of only a few thousand or a few tens of thousands, obviously that vaccine doesn't cover everybody. And so you have to make some decisions based on some factor as to who gets it first. And most of the governing bodies, including the Centers for Disease Control, the National Academy of Sciences, and several others, have really put a lot of thought into this, and including the Oklahoma State Department of Health put a lot of thought into their vaccine distribution plan. And so it's a risk-based approach. First of all, you want to start with the people who are at highest risk of dying from the infection, and you want to preserve the healthcare system. Because if the healthcare system goes down in a sense. If we lose all of our nurses or all of our physicians or all the folks who are working in the hospital to keep the hospital clean, we are not going to have hospitals to care for people, and then you'll have much higher mortality. So it's really a risk-based approach based on chances of dying from the virus, and then your chances of being exposed as part of your normal occupation, in a sense, in healthcare. After that, then it gets down to an age-based distribution plan, also for other risk factors, and then there are a whole variety of other gradations in that.
Do you think if a large portion of the population is vaccinated, will masks still need to be worn?
You know, so the question is basically getting at, when can we stop wearing masks? And I'm looking forward to that just as much as the next person. And I am hopeful that between lots of vaccination and then normal immunity and the change of seasons, that perhaps by the summertime we'll have such a low incidence of new infections that we can let them go, at least when we're out in public. I really don't know when we will be able to let them go in the hospital setting.
Let's go to Dr. Bratzler for a second. This is kind of unrelated to the vaccines, but I had a question about more Oklahoma localities than ever before have now enacted mask ordinances. That we're seeing are mask ordinances becoming less effective.
So first, I want to highlight that there have been additional studies published recently that show that masks are very, very effective at preventing person-to-person transmission of this virus. But that's not where this virus is being transmitted. If you have groups of people that are all wearing masks, that's not the people who are getting this infection right now. It's when you go into settings where you typically don't wear a mask, like restaurants or bars or gyms if they don't require masks, or places of worship that don't require masks. That's where the virus is spreading right now. So just because you have a mask ordinance in place, without limiting some of those activities or ensuring that people are wearing masks in some of those settings, we can't completely stop community spread of the virus. And there are multiple studies now. I saw another one this week that highlighted what are the top 5 places that people are getting this infection. And it's typically places like restaurants, bars, gyms, places of worship, places where you come indoors where there's some reason you're taking your mask off. That's where people get infected. So I still strongly support mask ordinances, and I agree with Dr. Drevets. It's going to be a while before we can tell people that it's safe to take your mask off. The other point I want to make is if you look at the vaccine trials, that for those that are coming out soon, we know they prevent symptomatic disease, people who actually get symptoms of COVID-19. We don't yet know whether, even if you've been vaccinated, if you're exposed to the virus, if you may still spread the virus but not get sick. We just don't know that yet. So again, I don't think we can put our mask away just because of vaccines coming out.
Okay, back to Dr. Drevets. I just have a couple more questions about the vaccine. Does it really make a difference if someone gets the Pfizer vaccine versus the Moderna vaccine? As a medical professional, are you hoping to, would you prefer one over the other, or is there no difference in your mind?
So before I answer that question, I want to tail off on something that Dr. Bratzler just said. You know, masks don't work if people don't wear them. And just because you have a mask on your face doesn't mean it's necessarily effective, because we all see people walking around with the mask like this. The virus seeks out your nose. This is where most of it goes when you, the receptors for it are. And if you're wearing your mask down on your chin, you're not helping yourself at all. So masks are like seat belts. They work if you wear them. They don't work if you don't. Just like your medicines in your medicine closet. Medicines don't work if people don't take them. So the question that the reporter asked was about the differences between the Moderna vaccine and the Pfizer product. So as far as the information that's been released so far, they seem to be probably equally effective. In general, somewhere around 95% effective in preventing symptomatic disease. One difference in the Moderna trial compared with the Pfizer trial is that all of the cases in the Moderna trial, of all the severe cases of COVID-19, they were all in the placebo group, none were in the vaccine group. In the Pfizer trial, there was one case of severe disease in the vaccine group, and I believe 9 in the placebo group. So they both appear to be highly effective in preventing disease. Whether or not this, the ability to prevent severe disease will be different between the two remains to be seen. As near as I can tell, they have relatively similar safety profiles. And again, this is just what's been published so far, and there will be much more data coming out when and if they receive emergency authorization. The biggest difference appears to be in the manufacturing process and then in the distribution, because the Pfizer product requires ultra cold temperatures. The Moderna product does not, and the Moderna product has a longer shelf life after it's been reconstituted. If I had the option of one or the other, it wouldn't matter to me which one I received.
And 95% efficacy is
Is
general?
really, really, really darn good.
Okay, say that the whole sentence.
So the question is 95% efficacy for a vaccine, is that good, is that average, or is that just mediocre? And it is really, really good. There are only a handful of vaccines that are better than that, and these would be things such as the tetanus toxoid vaccine. Measles vaccine, I believe, also has a very high efficacy rate. You get, on the other end of that, you get vaccines such as the annual flu vaccine, which may be 50 to 60% effective in a good year. And that has to do with the characteristics of the flu and the vaccine. So 95% efficacy is really good.
One last question about any idea where the vaccines will be distributed from? Partially that has to do with the cold part for Pfizer.
Right. So the question is about where will the vaccines be distributed from? And that will depend upon which vaccine is being received. Initially, the Pfizer products are going to large health centers and other places that have the capability for storage, and then those products will be distributed according to the state's distribution plan, mainly for healthcare workers. The Moderna product will then come in through the state. That will probably be distributed through other types of operations, perhaps through the city county health departments. And at some point, large pharmacy chains will also be involved, such as CVS or Walgreens, as this was part of Operation Warp Speed.
Dr. Bratzler? Corey at the Tulsa World says he knows you've spoken on this before, but he wants to get some fresh comments on at this point. What short and long-term concerns do you have for an Oklahoma population that's already unhealthy as elective or non-emergent surgeries are scaled back?
Yeah, so the question is about what could be the potential impact of scaling back certain elective operations or other things as the hospitals have gotten full. And of course, from a patient perspective, I would say most patients don't want, if they're scheduled and have planned for some elective operation, they don't want to delay that care. The other impact that we've seen is that when hospitals start delaying elective surgery and other things, and when the case counts get high and the news is bad about hospitalizations, people avoid even routine medical care like cancer screenings, routine immunizations. Kids, the number of kids that are getting all their childhood vaccines has dropped off fairly substantially also around the country. So all of those have the potential for long-term complications. So if you take cancer screening as an example, if people aren't getting routine cancer screening, and then ultimately we could see patients present down the road with later stage cancers that are more difficult to treat and have higher rates of complications and mortality. So we want people to continue to receive routine medical care. Please don't delay if you're hypertensive and diabetic, if you need vaccines, if you need cancer screenings. please don't delay those. We really need people to keep getting that. When you look at what the hospitals are doing right now, they're looking at limiting elective procedures for those procedures where it won't have a negative impact on the patient, but that particular patient, if they have that elective operation, might have to take a hospital bed. So as an example, somebody that needed to have their hip replaced because of just arthritis. Yes, it's very frustrating to that patient not to go ahead and get that operation done, and there could be some consequences of delaying the operation if the patient were to get sicker down the road. But that patient may end up in a hospital bed. It could reduce the capacity of the hospitals to take it, and it's considered an elective surgery because the patient didn't have an emergency and it's not a broken hip and those types of things. So there are certain operations that can be delayed if they don't have a negative impact on the patient, but there aren't that many.
That reminded me of another question for Dr. Drevets, sorry. We had been asked if people have underlying medical issues, autoimmune issues, if they have cancer, if they have some serious medical problem, when the vaccine is available, is there any data yet to know if those people should be vaccinated with the COVID vaccine?
So the question is about, should people with underlying health conditions receive the vaccine, and in particular, underlying conditions such as autoimmunity or autoimmune disease. So again, that's a sort of a nuanced answer, and the question is, in general, all folks with underlying health conditions should receive the vaccine. Folks who will have difficulty with the vaccine, and this is, I think, a theoretical possibility, and more data will be coming out on that. But when you think about it, if priming the immune response against COVID-19 triggers some kind of a negative side effect in somebody, the amount of stimulation they receive from the vaccine is many, many, many times less than the amount of stimulation their body would receive from having the actual infection. It's different by several orders of magnitude in terms of the T cell response and in terms of the host response, you might say. So if there is a chance of a negative effect on some underlying disease with the vaccine, the chances of a negative effect are many times higher if you actually have the wild type disease or the actual infection. And I hope I'm saying that right. So the idea would be that you're still preventing a worse outcome by taking the by taking the vaccination, because the infection itself would give you a worse outcome for whatever process you're worried about.
And especially in that population. I mean, it's the same thing they say probably, I think they say with the pneumonia vaccine, a cancer patient getting, or maybe somebody, an autoimmune disease, catching pneumonia is more dangerous than the chance of maybe any kind of reaction to the pneumonia vaccine.
Right, and so it's, the idea is that you're not non-specific, in terms of autoimmunity, a vaccination is not a unspecific or a non-specific boost to your immune system. A vaccine is a very specific training of the immune system to see a very particular part of a very particular pathogen and to focus an immune response around that. So you're receiving a very small amount of material in the vaccine. It's, I think in the Pfizer product, it's 30 micrograms of the product is what's injected. So that's really quite a small amount. You do get an immune response, but it is all in general focused around the specific antigen, which is the part of the virus that you're making the immune response to. You're not stimulating your immune response to every other infection or every other possible complication or every other possible condition that you could have. Are there vaccine reactions? Yes, there are. Are people sometimes allergic to vaccine-related products? Yes, that does sometimes happen. So clearly those things happen, but they need to be separated out from what is more common. And most commonly, it's these unspecific reactions such as fever, headache, and local pain.
We are actually way over time today, but we've got 2 more questions for Dr. Bratzler. Okay, where is it? Project Echo COVID data sessions. Jennifer Clark is a doctor with that program, said she fears her colleagues will soon have to practice under crisis standards of care if trends don't change. She cites Dr. Wendelbo's 8,000 per day case rate projection for early January. What thoughts do you have on this?
Yeah, so I guess the question largely is about what are we looking at for the future if we don't bend the curve? And there are a lot of different models out there that have predicted anywhere from 3,000 to 8,000 new cases on a daily basis if we don't bend the curve, particularly based on what we saw happen in the month of November. So I don't have a crystal ball to know how many cases per day. Most of the models project that we will hit our peak of hospitalizations and case counts somewhere around the first week to 10 days into January. And so that's why I'm saying right now we need the public for the next couple of months to really buckle down, to keep wearing your mask, avoid crowds, keep those family gatherings to a minimum, avoid indoor spaces where people aren't wearing masks. There is a glimmer of light at the end of a tunnel with vaccines as they get distributed, but just because they show up next week, it's still going to be several months down the road before we really see them impact the overall case rates.
Okay. We've seen people who have been deemed recovered from COVID still feel very tired and low energy months after the initial infection. Is there something to people who are saying, I got COVID and have never been the same? Can you ever go back to feeling normal again?
Yeah, so about a third of the people who have symptomatic COVID-19 will have persistent symptoms for some time. Fatigue is a very common one. Some people have headaches. Some people will have cough or shortness of breath for some period of time afterwards. It's pretty common. Most people do recover, but there is actually some discussion of almost like a chronic fatigue syndrome that occurs in some people who have recovered from COVID-19. So again, the majority will fully recover, but about a third will have symptoms that may persist for a number of weeks after they recover from the disease.